Hey everybody, it's Dr. Eric Walcabbage. We're back for another edition of the Thyroid Answers podcast. And today we're going to have a discussion on something called PCOS and how that might relate to thyroid physiology and maybe some of your chronic signs and symptoms. And maybe you'll understand that these two conditions, which many times people think are separate conditions, are really tied together. And we're going to have a discussion with somebody who is specializes in helping people with PCOS and hormones and has a background in physiology, especially with thyroid physiology. And so we brought Christa Elza on to talk to us today about PCOS. Christa, how are you?
Good. How are you?
I'm doing fantastic. So usually what I like to do is have somebody kind of initially give a little background on you. I think you're a nurse practitioner, right?
Yeah, that's right.
And somebody might say, okay, nurse practitioner, but is she more medically oriented? Is she more functionally medically or more functional medicine oriented? So give us your background, give us your story. I mean, how did you get into becoming becoming a nurse practitioner? And then how did you get into functional medicine?
Yeah, so I have been a nurse since 2000. And I worked in the hospital setting, became a nurse practitioner, worked in a clinic, focused mainly on hormone replacement, weight loss. And I was really finding that a lot of my patients felt good for a brief moment, or they would lose weight for a minute and would always come back not feeling great. And I started looking for other ways that I could really serve my patients. And the more I looked, the more I realized I had to stop band-aiding it. And that's kind of what drew me into functional medicine. So I started my training in functional medicine to really get to the root cause of why people couldn't lose weight, why they couldn't sleep. Why is a 35-year-old woman, why does she have high testosterone, or why does she have low testosterone? And how can we really get to the root of that? And so I've been studying that for the past couple of years. I actually left the clinic setting to create my own online virtual practice where I can really spend a lot more time individually with women in the group setting and in one-on-one settings. So I utilize all functional medicine testing to really look at deeper lab work so that we can find and resolve what's actually causing their symptoms.
Yeah, so I also worked in a hospital setting 30, 40 years ago. But what we see, I think we had a little discussion of this prior to this podcast. And one of the challenges I think that happens when you come from an allopathic background, allopathic training, and you come to functional medicine, sometimes we see that we bring an allopathic approach to functional medicine. So that can be a difficult thing to kind of not necessarily leave that training behind, but leave that mindset behind. So how hard of a process maybe was that for you to say, okay, that's the allopathic approach, and I don't want to just greenwash the allopathic approach. What I want to do is actually do what we call functional medicine, which is trying to address the root cause issues.
Yes, it is. It's almost like unlearning and then relearning. So when you look at thyroid dysfunction, when you look at high blood pressure, when you look at obesity, a lot of those things we would band-aid in a certain way. And it was almost like I had to unlearn that process and relearn. I do use supplements often for a period of time with my clients because I find that the body does need support. But really, a lot of the problems that we have boil down to lifestyle. And it comes down to how well are you moving your body? How well are you eating? What are you eating? How well are you hydrating? And so a lot of it is just teaching people also habit change, self-love, like ways to really embrace the fact that they've got to be a partner in their health. They need to be empowered to understand that they get to take control of their health. And so a lot of it has to do with mindset work also, to understand. So not only teaching them what's actually going on, but then just the mindset work of like, you are a partner in your health. You don't have to just go to a doctor to get a Band-Aid. And so it's been a process for sure.
Yeah. And that's not, and I want to make sure the listeners know, and I say this all the time, allopathic medicine is not bad, but allopathic medicine has a job, and that is to prevent you from dying, prevent you from bleeding out, manage your symptoms, manage your disease. But that is different than what functional medicine's job is. And functional medicine's job is to help you optimize your health, how to improve your health and your quality of life through modification of diet, lifestyle, and strategic supplemental strategies. And we shouldn't be pitting allopathic medicine against functional medicine. What we should be able to do is say, hey, listen, this is an acute situation. You need acute help. Let's get you some allopathic care for now. Once you're stable, then we can start working on how we got here to begin with. And for the person who doesn't want to put time and effort into improving their diet, their lifestyle, exercise, mindset, doing all the things that create a healthy life, then we need a safety net for them, which can be allopathic medicine. The challenge becomes when people have that mindset, and clients and or physicians have that mindset, well, medicine bad, supplement good. And so I'm going to replace one med with 3 supplements, and that's better. And I don't know that that's better. So I'm in line with you. We want to help somebody change and modify the diet, the lifestyle, the things that actually created their health issues, their crisis. I use my Shrek analogy all the time with people, because they always think that the last thing that happened to them is the thing. Like, I just got diagnosed with hypothyroidism. How do I fix it? Well, this glandular hypothyroid thing you have has probably been developing for the last 20 years. So it's the end stage, not the beginning. And I say people, there was a famous philosopher named Donkey, right? And he's walking through the field with Shrek, and he's telling Shrek, hey, ogres are like onions, you have to pull back the layers. And that's kind of how our health and our health conditions are. We think the thing we see is the issue, when in reality, there's a whole backstory there, right?
Right. Like, your symptoms or your diagnosis is actually the final stage of it.
Right.
And oftentimes, by the time you're so bad that you are diagnosable with something, there is a period of time that you just need support as you're building the lifestyle changes to kind of meet you there. And then the hope is always to taper off of medications, prescriptions, and supplements. And
that's often not the wheelhouse of the allopathic physician. They don't have the time, maybe the training from a functional or optimal health perspective. They're what they're doing on a daily basis and how they've been trained from a crisis management, symptom management, disease management standpoint is a little different than what we want to do in functional medicine. But when as you said, like, the diagnosis is often the end, and that couldn't be truer for thyroid physiology, because by the time somebody is actually diagnosed with primary hypothyroidism, they've lost 90% of the function of their thyroid gland. And so if you've lost 90% of the function of your thyroid gland, that didn't happen like overnight, like, oh, I woke up and now I don't have it. It's been a progressive, continual process that's occurred over time. And I would guess that PCOS is also very similar. You don't wake up one day and have PCOS. It's a condition that develops over time. So can you explain what PCOS is for people who have no idea? They've heard the term maybe, or maybe they haven't heard the term, but I think most of the people listening to this podcast have heard the term, but they're not really sure what it actually is.
Yeah, so PCOS stands for Polycystic Ovarian Syndrome. And it can affect up to 10, maybe even more, 10% of women. And oftentimes women don't understand that that's what's going on with them. They have symptoms like weight gain. They have symptoms like hair where they don't want it on their chin, around their nipple area, maybe even on their face. They tend to really have a problem with periods. Like, they're not having regular periods every month, and they think, okay, that's just the way my body works. Acne is another big symptom. Hair loss, particularly in the pattern of male pattern baldness. So it goes undiagnosed, unfortunately, in a lot of women. But it's characterized by having higher testosterone levels in the body, higher blood sugar levels, higher insulin levels. And it really can, it can have actually 4 different reasons. And so that's the other area where functional medicine can dive in there and say, well, great, you have these symptoms, but let's just see how do we, that's what I love about functional medicine, is that we're not just saying, okay, great, you have that, let me put you on this medication. It's what's causing that, because there can be 4 primary different reasons for PCOS. And so it's important to, number one, rule out hypothyroidism, because oftentimes, and we'll kind of get to that, but a lot of times women have both. They have hypothyroid and they have PCOS, or they could have primary hypothyroidism. So it's really important to rule that out first and foremost. But beyond that, you want your practitioner to really look at testosterone levels in your body. Where are you at with that? And free testosterone. You also want to look at something called sex hormone binding globulin to make sure that you aren't holding on to enough of the testosterone. So there's too much free testosterone and your body's responding to that. You want to look at progesterone, and you want to look at a fasting insulin. And I find a lot of practitioners don't look at fasting insulin. They look at A1C, which is it's an average of your blood sugar over the past 3 months. But what's important here is insulin and insulin resistance. That's a big driver of PCOS.
So let's push that aside for a second. We're going to go back a little bit, because I want people to understand what's happening at the ovary. When we talk about polycystic ovaries, what does that mean from a physician standpoint? How do you explain what that means to the person? When you say you have polycystic ovaries, they're going, what is that? What is that? Yeah. What is that? So what is happening at the tissue level that the person can get a visualization of what's going on?
So in normal ovulation, you're going to have a balance of luteinizing hormone and FSH, which is follicle stimulating hormone. And that is very important to have to help mature an actual follicle, an actual egg. But what happens is LH, or luteinizing hormone, tends to be the dominating hormone there. And that actually stimulates the ovary to produce more testosterone. So what we're looking at is it's not really actually a bunch of cysts, it's just fluid-filled sacs. It's basically immature follicles that never fully get to have their heyday. We should be ovulating 1, sometimes 2 eggs, but you really should have 1 blossoming egg. And what's happening there is that the hormones are out of balance, and so there's never really 1 full mature one that shines and gets to be expelled from the ovary.
Okay.
Ovulation.
That's good. So there are characteristics, right? There's diagnosable characteristics for somebody to get diagnosed with this condition, PCOS. You talked about they may have these signs and symptoms, but what are the things that we're looking at in the patient, big picture thinking, to say, okay, if they have these 1, 2, or 3 of these criteria, they've got PCOS?
Yeah, and different institutions kind of have different criteria. But the main criteria is irregular periods and androgen excess, meaning you've got higher testosterone levels than are normal in a woman. We should all have testosterone, but there is a range that is above normal for women. And so when you've got irregular periods, meaning you skip a period, you could go months without it, there's no rhyme or reason, you can't predict when you have a period, and coupled with blood work that shows high testosterone levels, there's a high probability that you do have PCOS.
Okay, yeah. So they're going to have potentially hyperandrogenism, which is too much androgen, right? They're going to have this dysmenorrhea, the abnormal cycle, maybe no cycle at all, maybe mid-cycle bleeding or breakthrough bleeding, maybe. And maybe they might have this look of this polycystic morphology, or this look when an ultrasound is done, right?
Correct. And, you know, some criteria say you have to have an ultrasound that has multiple sacs in the ovary, but that's not necessarily true. And I think that's where some women also get misdiagnosed, because that's not necessarily ruling it out.
Right. From I think there's like 4 criteria, right? So you have to have at least 2 of those 3 big things, right, to be diagnosed with PCOS.
Yep.
But if you didn't have the polycystic morphology, but you had the hyperandrogenism and you had the abnormal cycles, you can still get diagnosed with it, right?
Absolutely. Yes.
But then we want to start to go to that next level and look for what's going on here. And so we start talking about what might be driving this experience. And one of those things you talked about was too much androgen, and that how the excess androgen at the ovaries can cause these kind of lots of these immature follicles. We talk about insulin resistance as potential driver for that. Why would insulin be a driver of more polycystic ovary condition?
Yeah, so
problems at the ovaries.
There's definitely 4 types, and insulin resistance is the most common. So insulin suppresses, or it can drive up testosterone. Testosterone suppresses the release of, or the development of a healthy follicle. And we know when you release that healthy follicle, the corpus luteum, the casing, helps to release progesterone.
Mm-hmm.
Okay, and so it's kind of this vicious cycle. We don't have that. And so we tend to have that higher testosterone stays higher and converts more to estrogen. So we've got this huge imbalance there. Insulin resistance, like I said, is the main driver for most of these girls. And that increases adipose tissue because the more insulin that we have, the more drive we have to push our blood glucose into fat storage. And that kind of perpetuates the problem. You know, it's this vicious cycle of higher estrogen, higher insulin, higher testosterone, no ovulation, which doesn't balance out that progesterone.
Yeah, so that can tie into 2 things. Like when I think about PCOS, I think about it as a triad problem. We've got a hormone imbalance. We've got at the minimum, a tissue hypothyroid condition, and maybe a glandular problem as well. And the reason I say that is because you could have primary hypothyroidism, you get thyroid hormone, you can still have a tissue hypothyroidism going on, and you still have the problems. And then the third component is an immune problem. And as you're talking about testosterone and estrogen, for the listener, it's important to know that testosterone and estrogen regulate the immune system. And through your cycle, the immune system of your ovaries, your uterus, that whole area is in an ebb and flow, because at some points in time, the immune system is trying to protect that area so nothing comes in there. And at other periods of your cycle, the immune system has to calm way down so that this kind of foreign material coming in there, doesn't get killed off and broken down. So I do look at it as a combination of those 3 things. And I think when we talk about insulin resistance, I think this is one of the things that we go round and round about, things like, oh, it's because you have insulin resistance. And then I always typically ask the question like, okay, so why do you have insulin resistance? Yeah. And to me, and I'll let you kind of give your take, but I'll give you mine, and then you can agree or disagree and we can discuss it, is that it's really hard to have insulin resistance without already having a state of tissue hypothyroidism or cellular hypothyroidism. Because cells, I talk to my clients about this all the time, cells operate in 2 modes. They're either in low stress manufacturing mode, where they're making enzymes and hormones and bringing glucose in and making ATP and energy, or they are in a cell danger response. They're trying to protect themselves from some threat. And when a cell enters into a cell danger response, it wants to wall off the cell. That induces something called autophagy, where the cell can then start cleaning itself up and looking for the threat. But part of that process of the cell danger response, when you stiffen the cell membrane, you have a reduced transport of glucose into the cell and other things into the cell. And one of the big regulators of whether a cell is in manufacturing mode or the cell danger response is the amount of T3 inside the cell. And cells away from the thyroid gland have the ability to determine what happens to thyroid hormone. I think sometimes in allopathic medicine, it's the assumption is you just put T4 in, it's automatically going to convert to T3 inside the cell, and everything's going to work. So as long as I pump enough T4 in here to deplete TSH, I'm good. When in reality, that's not truly how thyroid physiology works. The thyroid gland makes thyroid hormone, and then the cells and tissues get to self-regulate. And why? What does that have to do with blood sugar regulation? Well, to get glucose into a cell post-meal, we typically use insulin-dependent receptors. So that means insulin helps get the glucose into the cell quickly. Insulin-type glucose transporters called GLUT4 are reliant on T3 to get to that cell membrane and to function appropriately. But even in a fasted state, all the glucose transporters require T3 inside the cell. So from my perspective and my research, it would be it'd be very, very difficult to not have a cell in a low T3 state and be insulin resistant, okay? Now, so when somebody says, hey, I've got insulin resistant PCOS, but I don't have a thyroid physiology, I don't have a thyroid problem, they may not have a thyroid gland problem. But I already am considering that they have a tissue hypothyroid condition going on.
Yes. And, one of the drivers for PCOS is inflammatory. So you could have, maybe you don't have an insulin resistance problem at the time, but you will eventually, most likely, if you've got inflammation. But inflammation, we know, drives cortisol. And cortisol can perpetuate the PCOS problem because it's putting the body now is in that fight or flight mode. It's prioritizing cortisol over progesterone. But the inflammation, I'm getting back to the thyroid. They all go hand in hand, right? And when we have high inflammation, we tend to have more reverse T3. So now we don't have as much active T3 that is available for the body to actually use, because that reverse T3, like you said, T3 is what we really need. I like to say slow thyroid, slow everything. Like if that conversion isn't happening, then we've got less active, like we need that T3 in our cells to promote every operating thing on the cellular level in our body.
Right. And so the inflammation is key because we know that PCOS is a chronic inflammatory condition, low-grade inflammation. And right. As I've talked about on the podcast multiple times, when you have inflammatory processes going on, you have a tendency to have initially an upregulation of deiodinase 2, the enzyme that converts T4 to T3 in a tissue. But then you start to also get the upregulation of deiodinase 3. And over time, you get the downregulation of D2 and more of that upregulation of D3. So that produces that low T3 state. Therefore, there's insulin resistance. The problem is all those glucose transporters don't fade out at the same time. The one that holds on the longest, unfortunately, is GLUT2, which helps export glucose out of the liver and export glucose into the adipose tissue. And so we know that there's also that tie between PCOS, obesity, inflammation, and thyroid physiology. So huge tie there. So for the listener, if you're thinking, well, I have insulin resistance, two things you want to consider. If I have insulin resistance, that's going to start to create some challenges, especially if you're in that reproductive age with hormone regulation.
Right.
It's going to potentially create some issues with pushing more of your nutrition into fat cells and exacerbating the condition, because now you create more inflammation and it does become that vicious cycle you were talking about earlier.
Yeah, and PCOS overall is an estrogen dominant situation, right? Because if we're not ovulating, we're not producing progesterone, and progesterone helps balance out the estrogen. And estrogen can cause two things where it can directly affect the thyroid. I mean, it increases the thyroid binding globulin, right? So that if we're constantly in a state of estrogen dominance, that estrogen is causing more of the thyroid binding globulin, which kind of paralyzes the hormone of the thyroid hormone circulating. The other thing is there has to be a good balance of estrogen. We want enough that really helps protect our immunity, because it can stimulate the immune system. But when you're in an estrogen dominant situation, it can lead you to more susceptibility to autoimmune. And of course, we know a major autoimmune disorder is Hashimoto's, which affects directly the thyroid. And so a lot of times women with PCOS will have concurrent Hashimoto's. And part of that,
huge tie for the two of them, for sure.
Huge tie. And, you know, the question is kind of what causes what, where is there interconnectedness? You know, the thyroid also really affects, and I mentioned this earlier in the podcast of, you need to rule out hypothyroid first because they are so similar. When you don't have, when you're running on low thyroid, that really stimulates, you know, from the hypothalamus, you got the hormone there that produces not only TSH, but also prolactin. So when there's a high drive for thyroid stimulating hormone, because our thyroid is low, there can also then be a stimulation of prolactin. And prolactin tells the ovary to not ovulate. So the thyroid itself can produce anovulatory cycles.
And it's not uncommon to see a polycystic morphology in somebody who just has hypothyroidism, right? Or Hashimoto's. You might see that morphology and not even have a diagnosis of PCOS yet see that morphology. So it does become really important. We'll talk about how you start to look at how to diagnose hypothyroidism in a sec, because I'm sure it's different. I'm hoping it's different than it was when you were allopathically trained. That's changed a little bit. But yeah, there's so much there when you were talking about the immune system. Definitely both testosterone, estrogen, progesterone all help regulate the immune system. So, you know, this idea that we have this clean thing, it's just hormones and it just does this, that's out the window. There's so much tie into all these systems that you really do when you're working with somebody. If you have PCOS and you want to work with somebody, the allopathic approach is going to be pretty streamlined. Hey, we're just going to try and manage this hormone-wise. But in functional medicine, hopefully you're working with a physician who's going to look at your immune system, your thyroid physiology, blood sugar regulation, hormone regulation, look at your detoxification pathways, all of those things, because it's this web of dysfunction that actually ultimately results in a condition like PCOS. So one of those things that you touched on, and I made a note to come back to it, but I think I just lost my thought for a second. So let's just jump back into some of the ideas. When we talk about main drivers, we talked about too much. Oh, that's what I wanted to ask you. You said, because we talked about hyperandrogenism at the start. And then you just said, and this is a condition that's associated with high estrogen. So if somebody's listening on that end, smarter than me, and they went, wait a minute, she just said before that it's high androgens, and now she's saying it's high estrogen. Which is it? How could it be both?
Yep. Well, two reasons. Number one, it may not necessarily be higher estrogen all of the time, but it's a higher estrogen to progesterone ratio. It's very important that during periods of time in our cycle that we have more progesterone than estrogen, because estrogen needs to be calmed down because estrogen can get a little crazy at times, right? Like we need her and then we don't need her to stay all the time. Like we need progesterone to say, all right, pack your things, ready to go. I'm doing my job here. And when you don't ovulate, that balance never occurs, right? And so wild sister estrogen is just having a heyday in the uterus and all those things. The other thing is testosterone. When we already have a higher level of testosterone, that converts to estrogen, right? Our body breaks hormones down and it converts things and it changes hormones. And so when we have a lot of aromatase, a lot of, changing from testosterone to estrogen, now we're perpetuating the problem because we have some of that testosterone converting over to estrogen. And so then I don't know if we're ready to talk about treatment, but it really, from a functional standpoint, becomes very important for our body to be able to handle and manage this level of estrogen and safely detox it out of the body.
Yeah, I think that's important for somebody to know. Like when we're talking about where's the estrogen come from, right? 50% is like ovarian driven, right? And 50% is really pretty much peripheral tissue driven from what's happening with DHEA and how that's impacting tissues.
And adipose tissue.
Right. And so you've got these peripheral tissues that can produce it. You've also got ovaries that can produce it. We just got done saying that, hey, if there's a chronic inflammatory response, that can affect thyroid physiology. If we start to have a thyroid physiology that's downregulated, especially if it's impacting the liver, now we've got another problem because now our detoxification pathways are slowed. So now we can have a situation where we're got a lot of androgen production, reduced or sluggish clearance. We're getting more estrogen production. It's not doing necessarily what it's supposed to be doing. And then we're trying to metabolize this again through maybe compromised detoxification pathways because of low thyroid physiology. And now we can wind up with both estrogen overload, androgen overload. Is that fair to say?
Absolutely. And our poor liver, right? I mean, our liver, we're expecting it to convert the T4 to T3. We're also expecting it to detoxify and disarm and prepare our estrogen for excretion. So we're asking a lot of our liver, right? And so, when we talk about lifestyle and we talk about getting to the root problem, we've got to focus on liver support, really not having crap diet all the time. It really puts more of an impact on the inflammatory process and the need for our body to detox. Alcohol, women love their wine, but at the same time, the liver has to prioritize the alcohol coming in. And so what happens now to our thyroid function and to our ability to detox these hormones that really need to be open and be utilizing all of the energy to manage these other issues.
And I think that's why it's so hard to try and say this is the one thing that causes PCOS, because PCOS is going to be a side effect of just of adapted physiology. And that's the way I try and get my clients to think about it. Like if you're seeing insulin resistance, if you're seeing changes in your hormone regulation, there's a stress response. The body is not putting the time and attention to normal homeostatic physiology because it's more focused on protection. And so now we're decreasing energy to detoxification pathways, to regulating a hormone cycle. And instead, we're ramping up the immune and inflammatory process. That's not necessarily broken physiology, it's adaptive physiology. And what I think makes us different in functional medicine is if we're doing a good job, we're saying, okay, your body's not broken, at least early on. What it's trying to do is protect you for something. Our job from a functional medicine standpoint is to help you understand what is that thing, right? What is that toxin or organism or whatever it is?
I love that when it comes to the mindset of my body's not broken, because it's not that you need to patch things up. You need to help support the body. The body is all of what's happening, the symptoms that you have almost always are a protective mechanism. The body is prioritizing, your body wants you to live. That's its main drive, right? So when we have symptoms, what are we doing in our lifestyle? What are we doing? What are we predisposed to? I mean, genetics do play a role a lot of times in Hashimoto's and PCOS. Does that mean if your mom had one of those that you will have it? No, but it does mean that you may need to support your body a little bit better in order to not. You might be a little bit more predisposed to it, but it does not mean that has to be the truth for your body.
Right. You're not doomed. And that would be that's a whole nother conversation to talk about the genetics and early development and how we could predispose our child to potentially have these things, but that's a another conversation. So when we're talking about somebody, we say, okay, we've got this diagnosis. What are the key criteria when you're looking at labs? You're saying, okay, this is a person I think I've got who's got PCOS. You're looking at symptoms. You talked about running their androgens, maybe looking at running their blood hormones. What other tests do you look at to help get a diagnosis of PCOS?
Well, again, remember, main focus would be, are they having irregular periods and do they have androgen excess? So obviously we're definitely going to be looking at total testosterone, free testosterone. DHEA, which is secreted from the adrenals, which is a precursor to testosterone. So I want to see what's going on there. And, you know, I would definitely look at the luteinizing hormone and that follicle stimulating hormone and see what is that ratio, because that's another indicator of who's kind of running the show there. I always look at progesterone, although that's kind of hard because that goes up and down throughout the cycle. So if someone is very irregular, it's hard to know exactly which time to test that. Fasting insulin, fasting blood sugar, and then an A1C. But again, fasting insulin is probably going to be the key to look at there. How hard is their pancreas working right now? How much, what's the level of insulin resistance? The other thing I love to use is Dutch test, which is that dried urine cortisol test. And so that really tells us a lot. You know, we collect the urine, we collect the saliva for a full 24-hour period. And that test tells us the metabolites of the estrogen and the testosterone and the progesterone. So it gives us kind of a reeling video instead of a snapshot picture of the hormones and what's at play in a 24-hour period. So that's helpful as well.
Yeah, I think taking a look at the blood test, the blood hormones has kind of been standard, and that's what you typically see in an allopathic model, and there's nothing wrong with that. I think the Dutch test adds another level of understanding, because sometimes, I'm sure you've seen this in practice, the blood hormones don't look that bad. You look at those blood hormones and then you look at the urine metabolites and you go, oh my God, okay, so we're really driving down maybe the alpha pathway. We've got lots of androgen being produced. We've got we can see some significant problems with the detoxification pathways. Maybe there's a significant methylation or sulfation issue that's going on. So I used to just run the Dutch, but now I have a tendency to run both of those simultaneously. And sometimes it's really helpful. A lot of times, I'd say 70% of the time they match pretty good. And then there's that 20 or 30% of the time where you go, these don't match up. And then it's a matter of trying to understand the mechanism. Why would they be a little bit different why is the Dutch not maybe matching up to the blood?
Yeah, well, and we know also, you know, that the brain pulses those hormones. And so when we're drawing the blood, it's just literally a snapshot of, the progesterone happened to be peaked at that moment because it was a pulse from the brain at that moment that you tested. Whereas the Dutch kind of takes all of that into account because, so it gives us that video play of what's really happening throughout the day instead of just that quick snapshot. The other thing, you know, obviously the Dutch shows that the blood work doesn't show us is that whole day worth of cortisol. And so that can really give us a window into adrenal health, because adrenals can also be a main driver of PCOS. And so if somebody is under a lot of stress, they could just be in overdrive. Their adrenals are making a lot of that DHEA. And so it's not insulin that's driving this higher testosterone, instead it's DHEA. And so that test can also kind of pinpoint, this is not necessarily an insulin resistant problem. This is a stress problem. And so that at that point, I would really work with someone on their lifestyle and on stress management and what can they change about that part, and what do they need to support their body in that avenue.
Yeah, I think that's a good point, because when you look at the Dutch, somebody may be seeing a really high DHA production and like, well, I'm not taking any DHA. Where's this coming from? Well, if you look at the DHA is elevated and the cortisol is elevated, typically you see those matched up together. I think that's a better scenario. If you have high stress and you have high DHA and high cortisol, I think it's a little bit more problematic when you see the high DHA and then you see that the cortisol production is not where it should be. That can create a little bit more of an issue or a problem. But yeah, I think the Dutch test is fantastic to take a look at. When you take a look at thyroid physiology, you're going to take a look at thyroid physiology as well, right?
Yes, absolutely. I would check a TSH, of course, but then a T4, a T3, a reverse T3. Again, if they've got a lot of stress, they might have more of that reverse T3. And then TPO antibodies for sure. Looking at antibodies to see, okay, is this a dual problem? And does this person, she's had all this estrogen dominance, does she now have an autoimmune disorder that's affecting the thyroid? that is perpetuating the whole picture.
Yeah, and for the listeners, you've heard me talk about this before, that you could have thyroiditis going on and not have thyroid antibodies. And that's important for people to understand. A lot of times people say, well, I don't have Hashimoto's because I don't have antibodies. Well, the only difference really between Hashimoto's and thyroiditis, Hashimoto's thyroiditis and thyroiditis is the antibodies. And typically 90% of the cases are Hashimoto's. It's probably higher than that because Hashimoto's is an immune-driven, lymphocyte-driven disorder, and antibodies may not show up in the early phase of thyroiditis. It may be into the later stage. So even if you have chronic hypothyroid symptoms, if you are insulin resistant, if you have PCOS, even if you don't have an elevated TSH or antibodies yet, it's still important to continue to get a look at that thyroid panel because you probably still may have a thyroiditis going on, but it may take a while before those antibodies show up. And I've talked about too, Christa she kind of talked about the insulin resistance. That could be an indicator that there's tissue hypothyroidism. Lipids could be an indicator that there is tissue hypothyroidism. So if cholesterol is elevated, LDL is elevated, that's a classic symptom that there's low T3 at the liver. If triglycerides are elevated and VLDL are elevated, that's again another indicator that there's potential tissue hypothyroidism. So I do have a Thyroid Thursday video. If you go back and check those out, where I kind of walk through about 7 or 8 tissue patterns of hypothyroidism that you could have tissue hypothyroidism, but still have a normal TSH and free T4. And in allopathic medicine, they're typically only running a TSH with reflex to T4, so they may not see that there's a lower T3 or free T3 or an elevated reverse T3. They don't run them. It's not important for their diagnosis. So this way, if you know that there's these patterns and somebody says, well, you just have prediabetes, you're just insulin resistant, that should ring a bell that, hey, that's one of those hypothyroid patterns. So maybe I do have a tissue or cellular hypothyroid issue going on.
Right.
So let's talk about, and this is harder in functional medicine than it is in allopathic medicine. So let's start with allopathic medicine. Somebody goes to their allopathic physician, they get diagnosed with PCOS. What's the standard treatment that they're going to typically get?
Well, first and foremost, most will say the birth control pill. Well, if you've got irregular periods, and let's just shut all the hormones down and we'll just kind of give it to you synthetically. The problem with that, I mean, yes, it does. It can lower the androgens. It can really help you have a normal cycle, but it's not a true cycle, right? We really want our body to be ovulating, and we know on the birth control pill, we're suppressing all of that. So it also can deplete B6, and that can affect mood. So for girls who have been on the birth control pill and they're moody, they're not feeling great, a lot of times it can be a B vitamin deficiency. So, there's pros and cons to birth control pill. That is kind of one of those hot topics. But birth control pill, number one, is across the board the most common one. The other one, especially if they're finding that the A1C is higher, on average your blood sugars are higher, they're going to put you on metformin. Metformin is a medication that does help with that insulin resistance. So your cells are more receptive to insulin, right? And then that's going to help promote ovulation. So metformin is another common one. In practice, I would use metformin. Before I had more tools, I would use that. And it can be really helpful for a period of time to kind of help support the body. But I wouldn't say long-term. It really can deplete B6 in our body. And so that's another really important vitamin that metformin does tend to suppress. But it can be helpful in increasing insulin sensitivity. The other one is spironolactone. That's another really common one that helps suppress androgen activity. But again, this one can prevent healthy ovulation, which we really want for these people, especially with spironolactone or with PCOS. So yes, it suppresses some of the testosterone, but it can also suppress the body's ability to ovulate. And also, if you're on spironolactone for acne, sometimes when you get off of it, you can have some really bad rebound acne with that spironolactone. So those I would say are the main three ones that I see prescribed often, just knee-jerk reaction with the diagnosis of PCOS.
And I'd agree that's what I've seen too. And there's, as you said, there's challenges with those. One, if you're suppressing the androgen, you're not addressing root issue. But that's again more of a allopathic approach. That's the kind of the standard. The functional approach would be to say, okay, well, why do I have it to begin with? The metformin, again, another approach. Like, hey, if the tissues are insulin resistant, let's just force it into the tissue, and that can be beneficial. The problem is that metformin suppresses TSH. So now you might be developing a hypothyroid condition finally, but this metformin is going to actually mask it for potentially a longer period of time if your prescribing doctor or the doctor running your TSH doesn't realize that metformin is suppressing the TSH. So you could show up saying, listen, my skin is dry, I'm constipated, I got no libido, my hair is thinning. And they look at your TSH and they go, no, it's good. And nothing else is done downstream because the metformin suppressed it still into normal range. And we do know that TSH doesn't necessarily reflect what's happening in all the cells and tissues. It cannot. And even small changes of TSH within the lab reference range are associated with tissue hypothyroidism. Like small changes in TSH, as TSH goes up, cholesterol and LDL go up. Well, what does that tell you? That tells you that there's a low tissue level. That's still, TSH is still normal. There's enough T4 impacting the hypothalamus, but not enough at the tissue level. So that becomes challenging. And I think they're good strategies short term. And that's where we need like more Christas who has allopathic and functional medicine to be able to say, hey, I can let me help bridge this gap and help that communication between allopathic medicine and functional medicine to say, hey, I understand why that's important, but we got to do more than that. We got to get them to the next step if this is a person who wants that, and not just tell them, hey, nice, pretty girl, this is just the way it's going to be, and just take the medication and pipe down. So the functional medicine piece, I almost hate to ask you it, because people ask me all the time, how do I fix my thyroid condition? How do I fix my PCOS? How do I fix my insulin resistance? And I always say, it depends, because everybody's different, right? But let me hear your take on it.
Well, it does depend. And it definitely, PCOS, we need to know what the driver is. Is it insulin resistance? Then, in that sense, we need to really focus on magnesium. A lot of people are low in magnesium, and magnesium glycinate, I would recommend for almost everybody anyway. So if you have PCOS or not, we all need magnesium. But that can really help our bodies naturally become more insulin sensitive. Zinc is another one that a lot of people are low in. So I recommend that across the board. Making sure we're focusing on lifestyle things. Like when we talk about insulin resistance, what can we do about that? Intermittent fasting. I know that's a whole other podcast, and that has to be that also has nuances because it's not for everyone. But I would say limiting your eating window to 8 to 10 hours in a day. Start out slow, but when we intermittent fast, or we don't eat overnight, obviously, and then when we push that to not eat until 10 a.m. or noon sometimes, and we only eat in an 8 to 10 hour window, we're giving our body a lot of time to not be needing to manage glucose from food, from external sources. And so that can really help improve the insulin sensitivity. Weightlifting is so important for women. And I really encourage women to build more muscle, because that in itself, muscles can utilize that glucose very easily. And that can help in that whole vicious cycle of insulin sensitivity, insulin resistance, right? And so muscle mass is very important. And then, as far as eating, so the intermittent fasting, but then also avoiding simple carbohydrates, really avoiding sugars, alcohols, things like that it's just not going to help the situation that's going on. And so when we talk about lifestyle and mindset, like understanding that the way that you eat is important. Toxins is a whole other podcast too, but you can do simple things like not eating out of plastic containers, not heating things in plastics, using glass, because that is a hormone disruptor. And we want to do all that we can that's in our control. I also encourage women to do clean beauty products, because a lot of beauty products, shampoos and makeups and face washes, look for clean beauty products, because that can also help relieve some of that stress that we have on our liver to detox, right? Because as we're putting toxins in our skin, it's absorbed straight in, our liver has to do something with that. So that's also important. Fiber is super important, fibrous vegetables. And then probiotics. Take a supplement, but you can also do things like sauerkraut and kimchi and things like that. So there's so much that we can do in just moving our body and how we choose to eat. And then the toxins, drinking from filtered water and using glass containers. Those are some foundational things that really can be applied to everyone.
Yeah. And somebody might listen to that and go, yeah, but I just need to know the thing to take to do it, right? And so what I want to emphasize, because Christa's saying it, I say it all the time. When Kelly's on, we had the same things in our book that's coming out, The Thyroid Debacle. We talk about that's the whole third part of the book is not on supplementation. It's all on diet, lifestyle modification, because those are the things that create the issue. Those are the things that can help reverse the issue. But the reason we talk about all these things is because it's different for everybody. But anything can push us from what we call normal cellular homeostatic physiology into a threat response. And once that occurs, part of that cell stress response is to downregulate your thyroid physiology. Depending on which tissues are being impacted by it, you may start off and it's only one tissue all by itself and a few cells, and then eventually it can start to encompass the whole physiology. But anything that drives that excessive cell stress response can put you into danger mode, trigger the inflammatory mechanisms, and downregulate energy to proper tissue physiology. And that can impact uterus, ovaries, liver,
Absolutely.
renal system, blood sugar regulation. And we look at all these things as separate, unrelated conditions, when in reality, they're all related. It's this web of either function or dysfunction. And that's where we should be shining in functional medicine, is helping our clients say, hey, I know you read that on a blog post somewhere, that this one supplement's going to cure your PCOS, but the chances of that happening are not very good if you have all these other things going on. If you're emotionally stressed out, if you're not getting sleep, if you're not breathing appropriately, especially through night, if you have a toxic diet, you got all these things. One of those things by itself may not be enough to push the needle to create that danger response, but it's the cumulative stress over time that eventually causes us to break and to be stuck in that danger mode. And part of our role as a functional practitioner is to help you start to reduce those stressors to a point that the danger response can go away. And now the cells can go like, oh, all right, now I can go back to normal operating physiology. And that's where we can use strategic supplemental protocols along with our diet and lifestyle to help encourage and recover. The thing I usually tell people is, like, if somebody's a mom, right, and it's New Year's Eve, they're having a big party, they're cooking a bunch of food, they're trying to clean the house, do the wash, all this stuff at one time, and their child's sitting at the kitchen island, and somebody breaks in and attacks their child, are they going to continue to cook, right? Are they going to pack everything up in nice glass Tupperware? Are they going to try and slide a load of wash in? Just let me vacuum the floor real quick. Let me go take a nap. Let me go have sex. Like, none of those other things that were really important are going to get done. And instead, all mom's time and attention is put to protecting their child, right? And so if I walked into that home and saw that, man, Christa left the stove on, the food's burning, the wash isn't done, there's clothes everywhere, nothing's vacuumed, should I assume that Christa's a terrible mother and housekeeper? Or should I ask the better question, which is, why is it like this? What else is going on here that I need to go understand so that this all makes sense?
I love that analogy. That is so tangible. And yeah, I love that.
And so that way we don't look at ourselves as broken. We say, no, I'm trying to protect myself. Now things will break in time, if we're in an adapted state for too long, things break down. We call that allostatic overload. But that's the important thing. And the other thing that's really important is that it takes time to recover. If somebody broke in and attacked Christa's child and she fought off that attacker, she's not going to go back to normal tomorrow. You're probably going to be on edge for weeks or months, right? Like, is the door locked? What's going on? Like, on edge. And that's how our cell physiology can be. We can get out of that danger mode for a short period of time, and another stress, we're back in it. And I think for me, when I'm working with clients, I want them to understand this is a process that God is here, and it's a process to get you better. And that's a really important thing for most people to understand, especially women who are struggling with thyroid issues or PCOS or endometriosis, because they're hoping that, hey, this 1 month of treatment is going to change 5, 10, 20 years of hormone dysregulation. And it really takes more time, right?
It really does. And it can be overwhelming. And I think, we've talked about so much interconnectedness and symptoms and things like that. And really what it boils down to is, yes, have grace with your body. Exactly what you said. This is not a Band-Aid fix. This is fixing it at the root. Also, when we boil down all this interconnectedness and symptoms, it comes down to inflammation, right? So when we do the things to calm the body, like not eating the crappy foods and drinking the amount of alcohol and not getting adequate sleep and just really abusing our body in that way, yeah, your body's allowed to say, okay, great, now I can clean up and I can do these other things. I've got the space and the capacity because I don't have all these alarms going off. Right. So I love that analogy. That's really great. I'm going to reuse that.
And it's, by all means, you steal whatever you need. But and I think for somebody who hears that, like inflammation, that doesn't mean inflammation's bad. Right?
Yep, absolutely.
Inflammation is a signal.
We need that response.
Right.
Yeah, we need that little kick in the pants. That's why, phytoestrogen, all those things that we get from, or antioxidants and things like that we get from fruits and vegetables. It's a small little stress response to say, wake up, wake up. We want that. It's when we're in overdrive all of the time that we start to see disease processes really start.
Yeah, because somebody would say, well, I'll just take Advil or Tylenol and I'll reduce inflammation, I'm good. And that's not what we want. We need inflammation. It's a signaling molecule. You were talking about exercise, how important it is. One of the worst things you could probably do is take some anti-inflammatories and then go exercise. Right? Because you need that inflammation. You need the tissue breakdown, the inflammation that occurs to trigger your stem cells to come in and build you a bigger, stronger muscle tomorrow. So if you're taking a bunch of Advil and Tylenol and anti-inflammatories and then going into exercise, not good. Right. So we have to have some. We just don't want too much. Everything's like the Three Little Bears story, right? Too little, not good. Too much, not good. We just need the right amount of the stuff, right?
It really is. When you talk about all the hormones too, you want these to kind of flow in a balance. You don't want too much estrogen. You don't want not enough. You don't want too much thyroid hormone. You don't want not enough. You've got to, and the body's great. The body's amazing at creating homeostasis. It's crazy how well our body does that, but we can't overstress. We can't steal the baby, right? We need to keep things, we need to support our body so that our body can support us, period.
Absolutely. So let's finish with that, because that was a good statement to finish with. But let's do this. Somebody's going, man, I like the way Christa thinks. How do I find more about Christa? Where can I go? Where can I find her talking, or where can I learn more about how to work with her? Give us some insight. I'll put it in the show stuff, but let people know where they can find it.
Great. Yes, you can just, my name on Instagram, Christa Elza just Christa Elza is the handle on Instagram. That's where I'm most active. I do have a site, elive-health.com. But I'm most active on my social media accounts. I love to interact with people there. So I look forward to any and all questions. This is a great conversation. I love just kind of nerding out on all of the ins and outs of why. And it's my goal. It's why I do what I do, to really help women in particular, for me, to be empowered in their body, to understand what's going on and to understand their options, so that they can really take that power back and play a role in their health.
Well, I appreciate you coming on. We have to finish up this conversation on another call, get a little bit more nerdy, maybe talk hormones and immune system function and suppression and link to autoimmunity. That would be a cool discussion to have too. So, Christa, thank you so much for coming on the Thyroid Answers podcast. And for everybody who got a chance to listen, you might need to listen to this one a second time to get all that stuff in. But please share it with whoever you know that's struggling with any issues, whether it's PCOS, hypothyroidism, or any health issues, because all the things we pretty much talk about in here go back to the same fundamental things. Improve your habits, your behaviors in your life, your diet, your nutrition, your exercise. And that's probably the best medicine you can provide yourself. Okay? Thanks, Christa.
Thanks.